Becky, are we ready?
Yes, we are. Let me just get plugged in here. Start recording then. And we want to welcome everyone today to the Behavioral Health Integration webinar. We're going to be hearing from Greene County General Hospital's Rural Health Clinic, and they are located in Linton, Indiana. The meeting today is co-hosted with Elizabeth Burrows. She's the consultant in the rural space here in Indiana, and also works with the State Office of Rural Health and has done some great work with rural clinics across the state. Joining us from the Greene team is Renee Ritette Ofterhide, and Renee is a clinical social worker specialist. She graduated with honors from Indiana University, and she has more than 26 years of diverse experience, especially in clinical social work. And Renee provides direct services, including interventions focused on interpersonal interaction, intrapsychic dynamics, and life management issues. We're also going to hear from Carolyn Sanuga, and Carolyn graduated with a BS and Master's from Indiana State University, and also obtained her BSW from Indiana State and MSW from University of Southern Indiana. And she's also done some work as an Indiana probation officer and has a great deal of experience in the area as well. Also joining them is Dr. Joshua Cullison, who is a board-certified family physician and a native of Eastern Greene County. He graduated from Indiana University School of Medicine after completing the Rural Medicine Education Program, and he spent 3 years in Peoria, Illinois, serving as the chief resident at Unity Point Methodist. And Dr. Cullison is the medical director for Greene County General Hospital's My Clinics. So at this time, I'll go ahead and turn it over to Elizabeth, and she will lead the program from here.
Thank you, Becky. So just setting a few ground rules. This is definitely a webinar that is about programmatic content. So the clinical care that's being provided, we have 3 clinicians with us on this call, so it's definitely a focus on how they deliver care, the care they're providing, the results they're seeing, and their challenges in providing integrated primary and behavioral health care. So we do ask that you not ask a lot of questions about billing. We will be having a separate billing webinar later in this year, and we will have billing experts on that call. If you have questions during the call, you can write them in the Zoom group chat box, and we can make sure to get those in. You also can email me, and I have my email in the Zoom group chat. Many of you have it, elizabethburrowsconsulting@gmail.com, and I can make sure those questions get asked, or you can wait till the end of the presentation. Additionally, we're not going to talk, please don't bring up about what level of providers and how to credential. We're going to have some education about that at a later time as well. So again, today is just about really clinical care, patient results, the patient experience, etc. I do want to say a special thank you to the entire Greene County General Hospital My Clinic team. We appreciate your time, and I know personally from knowing Renee and Dr. Cullison, you are going to be in for learning a lot today. So I want to thank them for their time as well as the rest of their team. Also, there is a program where we're working to provide additional services, me specifically, with the State Office of Rural Health and any rural health clinics or rural clinics in general that are working to do behavioral health integration. If you are interested in receiving free technical assistance, please send me an email, or you can contact me in any way. You also could contact David Conrad or Becky Royer, and they will be glad to get you in contact with me. Thank you so much for your time, and now to the main event. Here, I'm turning it over to Greene County.
And I just want to make sure that Greene County's line is unmuted. Elizabeth, are you able to hear?
No, all I am receiving is silence. I can see the slides are advancing, but I'm unable to hear anything. Are you muted, Greene County? Is RLL for IRHA? Can you unmute RLL, please?
Yes. What number would Greene County be calling from? I'd be happy to double check and make sure they're unmuted.
I think it's at 4481, 812-847-4481. Or it's
yeah,
RLL at the top.
They're unmuted.
Rachel?
Can you hear us?
Hello?
Now we can, but we have not been able to hear anything up until now, Dr. Hollison.
Okay, I'm sorry. I don't know what happened there, but we will go ahead and get started with some facts about mental health, and I'll let Renee talk to that.
Okay. Let me know if you can't hear me. Some of the key factors that we wanted to identify and share today was that 1 in 5 adults suffer from mental illness. 90 million Americans live in a mental health professional shortage area, and that would certainly include Greene County. Untreated mental illness that includes anxiety disorders, depression, bipolar disorders, and others result in life issues created with unemployment, potential homelessness, incarceration, deterioration, and suicide. Up to 45% of patients who die by suicide have actually visited their primary care providers within a month of their death. So these are all key factors that are part of our rural health identification for support and services for individuals in our community. And these factual pieces of information were highlighted in rural health toolkits in a website that's available to us.
So next slide. So primarily, our clinic it's a provider-based rural health clinic affiliated with Greene County General Hospital, which is a critical access hospital in our county. We actually have 4 rural health clinics throughout the county. I myself am located in Bloomfield. We also have a clinic in Linton, one in Westgate, and another in Worthington, Indiana. Our behavioral health is primarily supplied through licensed clinical social workers like Renee. I believe, Renee, you also work with the perinatal navigator. You may be able to speak more about that than I can. Mm-hmm. And I know you collaborate with others inside the hospital, so maybe you could talk more about how you collaborate with others and the perinatal navigator that we have here now.
I can let Carolyn speak too. She actually works directly with him, so we work with each other through consultations. I have the availability of meeting directly with the doctors and the nurse practitioners at each site. So if there is an emergency or if they have someone that they're talking to, then they can come directly to me and I can enter their medical session as well. So we have phone, we have email systems and referral, and the communication is very close and it's very, very helpful to be able to triage meeting mental health issues and behavioral health issues as well. So Carolyn works directly with the perinatal program, so she and I can work jointly with families, and we might both work together with the same family, but I'll let her speak to that.
Yes, I'm Carolyn. I work with the perinatal program. It is a new program for Greene County. I believe about June of last year it was put in place. We have a registered nurse, and she's also a lactation specialist. And then her and I work together closely. We're getting ready to hire a third person for our team who is going to be a community health worker. And from what I understand, this is going to be kind of the wave of the future, as the state is saying that community health workers and perinatal navigators will be put in each county in the state of Indiana. It's pretty exciting because we're able to offer a lot to the families that wouldn't be in place if the program wasn't there. We work with any family that has a mother of childbearing age, and we also work with the fathers and the mothers together. So it's a pretty broad spectrum of work we do. It's therapeutic, it's hands-on. Sometimes it's just good old-fashioned social work where we're helping find resources and solve dilemmas.
I want to talk a little bit about the process for referrals that Renee alluded to a little bit. So typically, if we identify a patient during an office visit that either voices interest in seeing a therapist or we think might benefit from that, we have a number of different ways to hand off that care. One, they could just simply make an appointment at the time that they check out. Since we share the same electronic health record and are located in the same office, we don't necessarily need to have a formal referral placed into the EMR, but that certainly can be done. Referrals can also be made via warm handoffs. For instance, if I identify someone that I'm going to refer to Renee or one of our mental health workers, and they're available right then, I could introduce the patient and the LCSW. They can have a little chat, and sometimes that can be very beneficial for the patient to kind of initially break that ice, get to know the person that they're going to be seeing. It just makes it more comfortable for the patient and potentially less awkward. And so that's primarily the way that we handle referrals. And I'll let kind of you guys talk about treatment and documentation.
Okay. I was going to actually mention to add to Dr. Collison is that our program now has been available long enough that we get quite a few referrals just through word of mouth and from other family members that we have helped and supported, where there's been a good experience, then they've been able to refer their friends and family members to us too. So they've been calling now and making appointments through that. So that's good too. It's really exciting to see that too, that it can be a good and positive experience. So for treatment and documentation, the process and the role of the therapist is really important to review with each patient as they come in the first time. They've all had a diverse experience, many of which have been into mental health facilities before. Some have been good experiences and some have not. So generally what I've been introducing is a short-term therapy solution-based treatment for people so that we can service more people. Long-term therapy is still something that's needed, but it's something that we evaluate and think about how can they have services that are going to be most effective for their life situation. But I do make a point to introduce to the people that we're working with that my role is to be an educator, supporter, a reference person to help them connect with services in the community that they may not be aware of, and maybe even to suggest that they return to services that they've had in the community that were helpful to them even in the past. So An educational approach in therapy is real important for people to be able to have a better and more clear understanding of the normalcy that's involved in their life stressors and their behavioral health and their mental health. So I call it the ABCs of therapy and of education, is that educating people leads them to new knowledge, and that education and knowledge is what brings personal empowerment to them. And that's really one of the key foundations of what we're trying to make sure that we do, is educate people in a different way, and then have a transition of education that leads to new tools and new opportunities for them to have healing experiences and to be able to experience a positive connection to their healthcare provider, their mental health, and their, and their community in general. So that educational piece is important. And then, of course, documentation validates everything that the patient does to cooperate with services, but also there's documentation that's critical to identify what skill areas as the medical providers and as LCSWs to identify what skills and what knowledge we have. So it's important to include that in documentation in a sessions note. So if there's a life experience that they're having that we're helping them to process in therapy, I call it a learning opportunity, and then I'll help to make a new connection for them in their learning opportunity and the life stressors that are involved. The treatment plans, as we identify those treatment plans, we engage the patient to participate in that process as well. So in the first and second session, sometimes I explain to them that it might take a little bit for them to identify other things that might be helpful. But it's important to include them in the development of that treatment plan as well.
Rachel, can you speak maybe about what the clinic is doing as far as marketing for our services?
Yes, our behavioral health has been shared via social media. We also list their services on our Greene County General Hospital website, and we have several brochures that include the behavioral health staff that we have available. I'd say our best marketing tool is, like Renee mentioned before, just word of mouth. These providers just provide some services that are so valuable and so important, and a lot of our patients, it's a word of mouth, praise for what they do that keeps people coming back. And our social workers, we have an administrative team that really supports behavioral health, not only in the clinics but in the hospital. So we have a great team here that provides services not only in the clinics but in the hospital and in the community.
I would speak a little bit about because how I feel from my perspective, how having integrated mental health can be helpful to treating patients. For one, I got to say that it was fairly easy, I feel like, for most of my patients to really buy into the thought of like a mental health worker or counselor being in the clinic. And I think that for most patients, I think they're probably more inclined to accept the referral or to come to the referral if they know that they're going to come to the doctor's office that they just left, and that they're familiar with the doctor's office, they're familiar with the setting, they're familiar with the nurses and the receptionists. And so I think that's a huge advantage, and I think patients like that. It's also very nice to talk to Renee about certain diagnoses that I'm considering, or if she alerts me that someone is really struggling, or things that maybe I should talk to them about. We can communicate with the messenger system on our EHR. That can be very helpful. Renee, how do you feel like our collaboration? We get to talk at least once a week.
Right. And I think one of the other advantages is that if there's a situation where we see a patient struggling and they have already established trust or an attachment to their medical provider, then Dr. Coulson, for example, and I have actually met with people together. And I think that that's very comfortable and they feel safe. So there's an emotional transfer from how much they've grown to trust him to me. And I think that's been a new and it's a remarkable thing to watch. And so many people that have mental illness don't have trusting relationships outside of their family doctor. And that's one of the elements of rural health that is an advantage. When there is time that is taken to dedicate to that familiar, it creates emotional safety. So it's such an advantage to have this type of healthcare and behavioral health.
I think probably from my perspective, probably one of the biggest barriers. I mean, certainly there's still a stigma, not only in rural communities, but just in the United States in general about mental health and seeking mental health services. So we still face those barriers. Getting patients to go to counseling and therapy can be a struggle. High no-show rates. I don't know the exact percentage or how you feel about your no-show rates. Is that the problem for you over there?
They're high, and I think one of the connections for me is people that are experiencing pain with their medical conditions, but also the county is so big that the lack of transportation and, and the economic situation is that they have to depend on other people. Sometimes they're not even aware of Medicaid transportation, that type of thing.
Yeah.
But the medical conditions and the pain elements are things that I actually have to work with patients on to talk to them about the importance of learning how to manage that. Means they need to get here, but on the flip side, not to risk their own safety.
To add to that, though, the system that we've set up, we have an LCSW who goes into each of the 4 clinics every week. So if there is a transportation barrier, that kind of provides that person in their locale within our county is large, as Renee said. So moving that person around rather than asking the person to move is huge as far as the barrier of transportation.
I hear time and time again that we could use like 2 or 3 or 4 more Renees. There's a big need out there, and as you all are probably aware, there's a big mental health worker shortage in rural areas in general, so we could always use more help. And then I know we weren't going to talk about the payment or reimbursement, but I know we've talked about that within our clinic. How do we get reimbursed for our services, especially with Medicaid? And that's a discussion for another time.
I'm going to let Renee talk about a success story with behavioral health. She has many success stories, but here's one that was especially important to her.
Okay. Well, this is one of the situations where we've been trying to stay on time, so I'll try to condense the story. The one example most recently was a single mom who came in with an 8-year-old child who she thought was possibly learning disabled and or ADHD and on the autism spectrum. So she had tried several times to approach the local mental health centers for support, and she didn't feel like the services fit or were compatible to what she needed. But in a very short amount of time, we worked on connecting her to a lot of resources. I explained to her what special education services could include and the development of an IEP. I talked with her about Bloomington, Indiana has just through IU, a huge amount of wonderful services for diagnosing autism appropriately and for connecting to community and local resources. So I found a website for her so that she could get signed up for free monthly newsletters. We talked about Terre Haute, Indiana, which is on the west side in another direction. But there's another facility that now has the development of ADA and all kinds of services for parents and children on the autism spectrum. So in addition, I spent some time working with her on changing some of her interaction with her 9-year-old for homework, for bedtime, to help with decreasing some of the temper tantrums. At the same time, while her anxiety was really out the roof, then creating some mild depression. So we also worked on teaching her some of the very basic coping skills of anxiety so that she could react more appropriately to her son's behavioral meltdowns, but also to get some support for her. So she got to a point where she was able to thank me several times to say that with everything, and she earned the credit because she followed through with everything that I had suggested. And she saw just a huge immediate difference in her child's behavior, but then was able to reach out to some of her other family and friends to ask for support in a different kind of way instead of isolating herself. So her anxiety, and she did those things for herself too. I utilized some handouts for her just as a touchstone, and so it was very rewarding in that 6 to 8 week time. And then we just set up a system where once she got connected to those other systems for her child, just to say, call me, you know, I'm here, and to offer her the pride and accomplishments of what she was able to succeed for her, you know, for her son and for herself. So really amazing.
That's wonderful, Renee. Thank you.
We do have one question on the chat box, and that is, what are suggestions for those of us who do not have social workers in our hospital? And that came from Jessica Troutman. Do you have any suggestions for that? One, right away, I'd say you need to hire some, because, or some mental health counselors for that. But I'll let the panel give you a professional answer.
Yeah.
We have Carolyn Suniga to answer this question.
If your resources are slim, I would start with grad students and implement some grad student work, because sometimes they end up being employees. That's to quote our CEO just this week when we had this conversation, so that didn't come from me. But that's a good resource because they could actually be, and you can correct me if I'm wrong, but I think they could be clinically supervised from a different position.
Mm-hmm.
Renee's shaking her head, so I got that right.
Yeah.
But I think that's a good resource that we overlook sometimes. It's just the students are almost out of the university.
Right. And keep in mind, too, that with your school systems, rural schools also have, through the Department of Education, they have a lot of financial support that each school system can apply for. So some schools, rural schools, actually do have home-based services that they can provide to students, you know, that are experiencing family dysfunction and individual type of things. And so each school has to choose, you know, what kind of services they apply for, you know, through foundations and that type of thing. But the Indiana Department of Education very, very much supports rural home-based services and, you know, social workers. So you're probably eligible for some things that you may not necessarily realize. In addition to the basic, as Rachel mentioned, your closest mental health centers also have, you know, really a huge range of support and services through foundations and grants and that type of thing too, but each one might be just a little bit different. But it's another resource to check in with.
Thank you, Renee.
This is Becky.
Do we
and
have
I
any
was
other
emailed-
questions?
This is Becky, and I was emailed a question. We're just a couple minutes over, but do you have a screening tool that you prefer to use with your behavioral health patients?
There's not one that I necessarily prefer. We're still working on the difference between the intake assessment and the information that's gathered for a medical appointment and the difference for the behavioral health. So we're still kind of exploring and making some decisions because your short-term based therapy and your solution-based therapy typically calls for more intense information about presently what's happening. So, we're still working on identifying what's going to be the most effective for our services.
I'd say from a medical standpoint, I utilize a PHQ-9 and a GAD-7 for just anxiety and depression. I have a few alcohol and drug screens too. There's one called a drug and alcohol abuse screen. It's called the DAST, D-A-S-T. There's one called the SOAP, S-O-P-P-R. That's for opioids. That's what I use clinically.
Right, and so those things, those that Dr. Carlson just mentioned are resources that are available to us to utilize. So we wouldn't want to take something different, less intense or more intense, so we want to make that compatible. So I look at those tools, and I wouldn't necessarily introduce a new one to provide at least a beginning point, but then we evaluate it as we go.
Thank you. Elizabeth, that was the only question that was sent to me.
All right, thanks everyone for your time. Rachel's been kind enough to provide her email if you want to ask any of the team questions directly. And again, thank you all for your time and your participation. We look forward to working with you on behavioral health integration.
Thank you. Have a good day.
Go Greene.
Bye-bye.
Bye.